Hi, my name is Liliana Kiros. I'm going to talk to you about vision and hearing as it is related to the aging process. To begin with, I'm going to discuss age-related concerns with vision, and then later I'll touch on hearing and how that is affected as a result of aging as well. So essentially, as we age, our vision changes occur both functionally and structurally. This causes changes within the quality of life that we live, and so most times this translates to negative effects in which not only patients but us as well have to adapt to find new ways to make these changes easier to live with and cope with. So moving on to vision changes as a result of aging, you see things like decreased eyelid elasticity, which is known as drooping, also known as senile ptosis. Severe cases of eyelid drooping can actually completely block vision if the eyelid sags far enough. Orbicular muscle spasms cause lids to turn inward, which is also called entropion. And in this case, the lower lashes curl inward and irritate, possibly even scratching the cornea, which sometimes surgery is needed to prevent permanent damage in that case. Also, we have ectropion, which is the outturning of the lower lid, which causes dry eye just because the tears are not properly lubricating the eye. And this is a result of a decrease in goblet cells. And when there's a decrease in these goblet cells, there can be a possibility of a severe lack of lubrication, which would be known at that point as dry eye syndrome. Next slide. In the ocular space, age-related changes involving the cornea, as far as it becoming flatter, less smooth, and even thicker, can result as hyperopia, which is just a condition where nearby objects are blurry. The anterior chamber decreases slightly in size and in capacity due to the lens thickening, and even further, glaucoma can be a possibility with resulting in increased intraocular pressure. Reduced responsiveness of the pupils along with changes of the lens results in reduced accommodation, and this is where you see the need of older adults to have better lighting and things like that to see whatever it is they need to see. Also, there's an increased light scattering and a color perception decrease. So eventually, this just means that people need 3 times as much as lighting to see things as opposed to what they used to need in their 20s, if that makes sense. Next slide. Intraocularly, we're looking at color clarity diminishing resulting from retina changes. In chapter 19, Tui and Jet discuss colors like reds and oranges and yellows as being colors that are easier to see as opposed to darker colors like blues and greens and purples. Another notable change involves the decreased numbers of rods and associated peripheral nerves, causing either a loss of peripheral vision or just blurred peripheral vision. Visual assessments. As far as visual assessments go, we need to conduct a health history, which includes a social history and just a bank of questions, really, that would help figure out what's really going on with this patient. And these can be questions like, is there anyone in your family that has had glaucoma? Have you experienced any recent changes in vision? Really questions that are just going to facilitate trying to figure out what is happening with this patient. and their changes in vision. After that, you would do your inspection, your palpation, and then if there's any need for vision testing procedures, that would take place after that. Although there are a lot of vision procedures, diagnostic tests, just to mention a few. One of them is fluorescent angiography, which is to assess for retinal circulation, like those that would occur in diabetic retinopathy. Tonometry is used to assess for an increase in intraocular pressure and to assess for the potential of glaucoma. And then there are the more simple basic exams that are more popular, like the Snellen eye chart, which is to measure vision relating to distance. Moving on to the pathophysiology of diseases specific to vision. You have things like cataracts, which essentially form over time without any pain, and basically it's lens losing their transparency. A common symptom of cataracts is blurred vision. Next, you have your glaucoma, which can damage the optic nerve. It's a group of diseases, and common signs include things like headache, poor vision and dim lighting, increased sensitivity to glare, or things like impaired peripheral vision. Then you have things like diabetic retinopathy, which causes damage to the blood vessels of the light-sensitive tissue located in the back of the eye. Then you have your age-related macular degeneration, which causes a loss of central vision due to damage of the macula. And then last, what I have listed is a detached retina. It is a medical emergency where treatment is required, or the potential of permanent vision loss can occur. The symptoms of retinal detachment are an increase in the number of floaters or possibly even light flashes in the eye. So in an effort to promote healthy eyes and good vision, we need to make sure to educate the patient not only on smoking, but also to eat a healthy diet that is rich in green leafy vegetables. Also a diet that includes a lot of fish, that's rich in fish. And this is because the chances to develop age-related eye diseases is increased if patients are already having conditions like diabetes and hypertension and things like that. So we need to make sure to emphasize exercise, maintaining normal blood pressure and blood glucose measurements. We need to talk to them about wearing eye protective gear, whether that is because they're being exposed to the sun for long periods of time, or because wherever they work, or whatever is causing them to need protective eye gear. Last but not least, we need to advocate for routine eye care visits. So essentially telling these patients, to come in annually after, the age of 65, or come in annually after the diagnosis of diabetes 2, type 2, or just things like that. We need to advocate for them to be checking up on how they're doing and where they're at with their vision. Okay, moving on to hearing. So, hearing-related age changes many times are almost ignored because with older adults, we almost just assume that over time they just can't hear us. And we don't really, there hasn't been a lot of investigation to decipher if they really cannot hear, or if there's something simple like they have an earwax occlusion because they were cleaning their ears with a Q-tip. So it's important to take note that a lot of times hearing is a lack of hearing and a loss of hearing is overshadowed and not really paid attention to. And so it's also important to note that just like vision affects the quality of life, hearing as well affects quality of life. And in ways like miscommunication and hearing loss can lead to falls and safety, realm of safety risks, and a loss of even self-esteem. And all of these are just greater possibilities when we overshadow age-induced hearing loss. So what do these changes as a result of aging look like? Well, they look like decrease in, or changes in appearance, decreases in elasticity, the auricle losing flexibility, becoming larger and wider. On an otoscopic examination, seeing tympanic membranes appear more dull and gray, cerumen glands atrophy, and causing, which if your cerumen glands atrophy, they cause thicker and drier wax, which, as I mentioned earlier, can be a temporary reversible obstructive hearing loss cause. Presbyacusis is sensorineural, which is one of the two major types of hearing loss. And it essentially results when the joint between the malleus and the stapes becomes calcified. So on assessment, we need to use a focused assessment to evaluate hearing and hearing loss. We need to do not only a focused assessment, but a physical examination to rule out things like potential earwax occlusions before jumping to, oh, this elder adult just can't hear me and he's deaf, kind of thing. Ask the patient about history with noise exposure or things like past injuries, anything really that would lead to figuring out what the potential cause of the hearing loss is. So there are two types of hearing loss. One is sensorineural, which is just the damage to any part of the inner ear or neural pathways to the brain that would transmit signals to the brain. And then the other is conductive hearing loss, which is just abnormalities of the outer ear and things that inhibit the transfer of sounds and signals from the outer ear to the middle ear. And this can be anything from otosclerosis to infection to perforated eardrums to fluid in the middle of the ear, even tumors. So all of these would just fall under conductive hearing loss. And then to conclude, keeping in mind education for hearing, we want to educate patients and their families on how to use assistive devices, on what assistive devices are even available to them, reviewing medications just in case there's any medications that are contributing to hearing loss, teaching about how hearing loss occurs and the manifestations of it, early signs of it, late signs of it, when to come in, informing them about environments to avoid, whether it's concerts or just loud areas, and then working with families to develop better strategies to communicate with whoever it is that's having hearing loss, whether it's looking at them or using paper to write things down to make sure that there is no miscommunication. happening that would contribute to